And we'll record on the phone as well. So we're doing EKGs. We're going to go over ectopy, AV blocks, junctional rhythms, idioventricular rhythms, and some treatments. So we're mostly going over interpretation, right? Interpreting these things. All right, so this is very informal. So I'll pull up some websites that I've not vetted. So they are appropriate websites, but they have, I can't guarantee all the examples will be perfect, but we'll go over some examples here and there too. All right, so starting with EKG, so we're going over ectopy, right? Just put text here. So we're doing some ectopy, right? And the ones I want you to know are just PVCs and PACs, right? And then we're going to go over some AV blocks. And what are the AV? How many AV blocks are there? There are 3 blocks, right? Technically, and then has 2 of them, right? We got type 1 and type 2, right? So second degree type 2, second degree type 1, right? And then we have what else? We have some, we're going to talk about junctional versus idioventricular, right? They both have an accelerated form, right? And one of them has a tachycardia, right? Which one's that? Junctional only, right? Just to define those rates, right? So this one's real quick to define. So junctional is always a rate of 40, I think I heard, right? 40 to 60, right? Whereas idioventricular is 20 to 40, correct? Is that what the notes say? Okay. And then accelerated for both of these are going to be more than 60 or more than 40, right? And then junctional tachycardia is the only one where it's greater than 100, right? So that's like the only exception to that rule. Does that make sense? So if we were to like do a little analogy here, so we have, let's say we have a scale here, right? Oop, that's not a straight line. Let's move this guy around. Right, so we have a line here, right? Got 20, we got 40, we got 60, we got 100 over here, right? That makes sense. So we got 20, 40, 60, and 100. So we just said 100 plus was what? Right, so greater than 100 is junctional tachycardia. Okay. So there's that. And then what's 60 to 100? That's going to be accelerated junctional. Is that going to erase that one? Sorry, it's acting funny. Accelerated junctional and accelerated tachycardia, or sorry, accelerated idioventricular. Right? So on the bottom here, we'll do idioventricular. Up top, 40 to 60 is junctional, right? And then over here, what's 40 to 60? Technically, I messed up. I should have grabbed this here. I don't think I can move it. So if it's greater than 40, it's going to be accelerated idioventricular. So misspoke there. So accelerated idioventricular. Right? There's no such thing as idioventricular tachycardia. It's just accelerated idioventricular and on. So really don't have accelerated idioventricular that's going to be 100, but technically, if it was, that's what it would be, right? So accelerated idioventricular is 40 plus. Does that make sense? And then 20 to 40, that's our natural idioventricular rhythms. That help to see it on a timeline. Okay, so on the bottom here, we have idioventricular. On the top here, we have junctional rhythms. So junctional rhythms are 40 to 60, 60 to 100, or 100 plus, right? And it has three names to it. Okay. The last thing we were talking about today was treatment. Right, and that we'll look at a chart to look at treatment. That's the best way to delineate treatments, right? All right, so that's that. So it's all right. So AV blocks, right? So AV blocks. You want to be able to, you can do like 3 different charts to be able to, or 3 different flow charts, because it's impossible to memorize all the different combinations. You can't say, well, it has a regular and then it's wide and then it has a low rate and it has this and that. You can't memorize that for each one. You have to have a little flow chart to get you to the right answer every time. So I gave one in lecture, right? So what was the example in lecture? We started out with the PR interval, right? PR interval greater than 0.20, right? Likely we have an AV block, right? Next step we're going to see is there a dropped QRS, right? The nice thing about drop QRS is it has to be a second degree block, right? It's not going to be a first or third degree block. So we've kind of eliminated that. Where's my drawing at? There we go. All right. Oop, oop. So we have yes over here and we have no over here. Okay. So if a drop QRS is the next question, right? So if it's drop QRS, we have to have a second degree block. It's a second degree something. Okay. If you have a drop QRS, second degree. Okay, so if it's a yes, it's a second degree block. If it's a no, it's either a first or third degree block. All right, does that make sense? All right, so second degree type 1 or type 2. So we have options. Is it type 1 or type 2 second degree? Okay, so how do you tell the difference? It's a PR interval longer, right? Or PR the same, right? If it's PR longer, then it's going to be second degree type 1. Right, which is your Wenke Bach. Likely, I'm going to just have second degree type 1 because I don't like putting names, but I'll try to remember to put it. And if you have a question on the test, like is this a Wenke Bach or not, I'll answer your question. Right, and our other option is second degree type 2. That's if it's not longer. And put a little asterisk there because may have normal PR interval. Right, that's one of the caveats to second degree type 2s. Right. So let's finish our flow chart here. So we have next step is PR longer. It's a yes, it's second degree type 1. If it's not, meaning that we have a drop QRS and we have a PR that's not longer. It's just a PR interval that's fixed, right? So we can put that in text form. So no, it's not getting longer. It's a fixed PR interval, right? It may be greater than 0.20, it may be the same. In fact, these are the only second degree blocks, or the only time you have drop QRSs ever. That's the only time it ever happens. If you ever see a drop QRS, you're guaranteed to have a second degree block. And then it's a flip of the coin whether you got the right one or not, type 1 or type 2, right? And then PR interval longer, that's a yes. And that means we have a Wenke Bach. We have a second degree type 1. Okay, so our other option is we don't have a drop QRS, meaning that all the complexes are there, right? So it's a no over here. And it usually means it's a regular, it's sometimes regular. It's 100% regular here, but again, our second degree type 2s, they're the ones that don't fit the mold, right? They all sometimes regular. That's just with our second degree type 2s. Okay. It's like really high degree blocks. But again, I'm on the test, I'm not going to likely give you a really tricky second degree block or a tricky first degree block. It's going to be obviously it's second degree block if you know there's a drop QRS and it's getting longer, second degree type 1. If it's drop QRS and it's the same, then it's a second degree type 2, right? So, and then in real life, again, it can be tricky like that, where you just have to then, oh, but actually there's this little piece, out there. There are little details and exceptions, but I'm not testing you on exceptions. I'm testing you on the most common things, the most common presentation of things, right? So we have drop QRS, no. So that means we either have what's left over for AV blocks, first and third. So really, what I usually say is the PR interval ridiculous, right? Meaning that's like greater than 0.40. It's a ridiculous PR interval, right? And then we either have a first degree block, right? So which means that we have a P wave with every QRS, right? Or we have a third degree, which means they're divorced, right? You can say even the P to P and R to R interval are different. There's AV dissociation. They are divorced, right? Whatever makes more sense to you, right? You have a third degree block. So we have PR ridiculous, yes, or PR ridiculous, yes. And I did this backwards, but I can't move the text after the fact. Sorry. Sorry, there's people in the waiting room, which I forgot. So sorry for the guys in the waiting room. Okay. All right, so yeah, so here I did this backwards, but I can't move my text. But the one in the lecture is accurate, so apologies for that. Yeah, applications, my people at. All right, so that's I did it backwards here, so I apologize. So as a no, PR is not ridiculous, right? Then it's going to be a first degree. If it is ridiculous, then it's a third degree. Okay, so we'll refer back to this, right? So we'll save this and let's look at some examples. So again, I did not vet these examples. We're just going to Google and we're going to find some examples out there. All right, so let's do a new share for the screen. All right. So let's do a new window here. So let's do second, we want to do AV blocks, right? The examples I want to do. Examples. All right, let's see if this one's good. Has 3 examples, then I'm not good. All right, so we got a library here. These are all third degree blocks. No, sorry, that's getting in the way. Pearls, let's do hundreds of examples. Or library is a good word too. These different practices, and it has the answer at the bottom. Okay, this has, let's use this. This has a whole bunch of examples. Okay, so that just goes over how to interpret it, and I think these are all blocks, right? Hopefully. Where are the examples at? Practice. All right, so what is this one? Let's zoom this guy in. It's black and white from the 70s, but that's okay. All right, so what do we have here? So we have some, it's not irregular, but I got some drop beats here, right? Are they dropped or is it a third degree block? All right, so first I told you, let's go back to our flow chart. PR interval, is the PR interval prolonged, right? This PR is prolonged to the point of ridiculousness, right? So I'm thinking it's probably third degree is my first thought here. And the way I can verify that, because I could say, oh yeah, these look like drop QRS complexes, but there is actually there's divorce in afoot, right? If we look at our P to P interval here, right? So if we go from here to here, right? And we're to march that out, can you even see that? Let's burn that up, in red. Right, so there's our P to P interval. See how that looks kind of nice and even? That's my P to P. Right, that's divorce. It's doing its own thing compared to the ventricles, right? So let's do ventricles in brown, right? So there's my ventricular rate. And there's my other ventricular rate there. So those intervals look different, right? There's my R to R. Up top was my P to P, right? So those are different. So that's one criteria. Also, AV dissociation. After every P wave, there should be a QRS. That means they're associated. If after every P wave, there's not a QRS, they are disassociated, right? So you can argue like this guy over here. It's like, oh, but there was a P wave and a QRS, but we got to look at the whole picture. Yeah, there was a P wave and a QRS, but then how do you explain the lack of QRS over here, right? Was it a block of some sort? No, because their intervals are different, right? If it was a block, we would see PQRS, and then all of a sudden later there'd be like drop QRSs, right? So this is a what kind of block? It's a third degree block. So let's save this as a picture, saved in folder, all right? Let's see if we were right, or I was just making stuff up. Third degree AV block, right? And I'll share this document here, so I'll download it as AV block examples. And I'll remember to upload that somewhere. All right, so let's clear all drawings. Let's go to the next one. Let me know when you're tired of interpreting blocks. Okay. All right, so then this one, what's going on here? First, I told you this to start from our flow chart. We're going to look at PR interval. that looks, why is it yellow? All right, let's go to red. So line one up here. All right, so the PR interval is just barely 0.20, but what I have, remember I said if there's a drop QRS, that's always a second degree block. And remember, there's a little tiny exception of second degree blocks can have normal PR intervals. All right, so the fact that I have a drop QRS there, do you have any drop QRSs anywhere else? No, P wave, QRS, T wave. So I got some AV association. This is not a third degree, right? These guys are married. There's P QRS, P QRS, P, whoop, nothing, right? So what is the cause of that? So to differentiate, we know it's a second degree block because we have a drop QRS, right? So the next step is, do we have a PR interval that's getting longer, or we do not have a PR that's getting longer? So we do not, right? These guys look, are they getting longer? I gotta take another look at that. So this guy is what, 1, 2, 3, 4, 5 boxes. This guy is 1, 2, 3, 4, 5, 6 boxes. Is 1, 2, 3, 4, 5, 6, 7, 8, 7.5 boxes. So that it is getting longer, right? It's getting longer, right? So this is a type 1 block. Sorry, a second degree type 1 block. Type 1. Okay. So that's why we have to go down our algorithm, because it's impossible to memorize all the kind of permutations that are possible with that, right? So let's see what else. All right, so let's clear this guy out, clear all drawings, go to the next one. So this guy, oh, that looks irregular. And I can already say if it's irregular, it's probably a second degree block, right? But to confirm that, I got something dropped right there. Beforehand, we had something dropped there. Probably had something dropped there. But if I have a drop QRS in all of EKG worlds, drop QRSs are second degree blocks. Okay. So I had to figure out if it's a second degree type 1 or type 2. All right. And I could start at PR interval, right? PR interval is not greater than a big box. A big box is worth how much? 0.20, right? So it's not greater than 0.20, but I know there's a little tiny exception, right? So do I have a getting longer? No, they look the same. All you guys just have a drop QRS all of a sudden, right? So that means it's a second degree type 2 block, right? Because secondary type 2 blocks have a drop QRS and they have a PR interval that's consistent. There's a drop QRS and PR interval that get longer. What is it? It's a secondary type 1 block. Okay, so let's save that. That makes sense later. Let's go to mouse, bring this guy down. All right, this one. Oop. That looks irregular. I got something looks like some drop complexes just off the bat, right? Got something going on there, something going on there. This is an irregular rhythm, right? So that means I'm automatically a second degree block. Next step is look at the PR interval, right? Is it again for second degree blocks? The only difference is it longer, or is it consistent? So we got a PR interval here, here. That's longer drop. So that is a second degree type 1. Okay. Next one's clear this one out. This guy from LMS.RN is a winner today. Has all the answers, all the examples at least. This one, nothing's dropped, so it's probably not going to be a second degree block. We'll take another look, but P wave, QRS, P wave, QRS. Those look pretty associated, right? PR interval is what? Bigger than a 0.20. So right there, 0.20 plus 2 or 3 boxes, right? Like 0.26, 0.28, somewhere in there, right? So that is what? It's a secondary type 1, right? The PR interval is not ridiculous and it's not divorced. Sorry, what did I say? I zoned out. What did I say? I said second degree, sorry. It's a first degree block, right? Because we have a prolonged PR interval and the difference between a first degree and a third degree is a what? Is the fact there's associated or not. So if we look at the P rate and the R rate, they are the same. All right, let's undo that one. Right. If we were to measure this, right, use our calipers and measure that, that's the same. Okay, so P to P and the R to R are the same rate. There's a P wave after every QRS. That looks good and it's not ridiculous. It's like jealous couple. It's like those guys. Come on. All right. This one, it looks like a regular rhythm, but it might be, I got drop QRS complexes, or do I have drop QRS complexes, or do I have a third degree block? So I gotta look more carefully, right? So first of all, this QRS, this PR interval is 0.20, 0.40. It's getting borderline ridiculous, right? So I'm kind of leaning towards third degree. Like I could say, well, do they have a drop QRS complex or what, right? But this, what's going on there? That's weird. Why is the P wave all snugged up against there, right? And why is this P wave buried inside the ST segment, right? So that looks like the P wave is doing its own thing. So if we look at the P waves, right? This is the P rate here, right? It looks like it's even buried inside the T segment, the T wave. So here's a normal T wave, right? Well, that's kind of, you can argue that one, but unless I didn't draw a straight line. Either way, it looks like that is, we got a ridiculous PR interval, we got a P rate that's that, and we have an R rate that is this, right? We have different rates here. So that's a what? A third degree AV block, right? So let's save this and we'll move on here. All right, this one. What is this? First, I'm going to look at the PR interval, right? PR interval is not prolonged just yet. Got nothing there. Do I have a drop QRS complex or do I have AV dissociation? I get that. That looks like it's associated right there, right? That PQRS, that's associated, right? But I have drop beats. It is trying to be a third degree block. It's a wannabe third degree block, right? So I have drop QRS complexes. So if I have a drop QRS complex and PR intervals that are consistent, what is that? Second degree type 2. And second degree type 2 blocks that get more and more blocky, they get more and more blockade, can lead to third degree blocks. So eventually this is going to be so blocked that they're going to do their own thing. Okay. So this is a what again? A second degree type 2 block, because the PR interval was not getting longer. The PR interval was consistent. The PR interval was normal, because remember it has like 2 exceptions to it, right? Because sometimes it can be regular and sometimes it can have a normal PR interval. Yes.
Last one you showed. So how do you know that this one for sure is dropped and the other one?
Because the P waves on the previous one were looking funny in that they were like in the ST segment and they were like nuzzled right up against the QRS. Whereas here, they're always the same distance from the QRS when they appear, right? So the question for those listening was, how do I tell these P waves are appropriate and associated versus the previous ones? Or the previous ones they were kind of in the ST segment, right? And they were in the QRS, and they were different distances away from the QRS. Whereas here, they're the same distance away from the QRS. So this is the P wave P rate here technically to be higher, and yes, they are going to be different, but the fact that we have drop QRS complexes is really what's telling us that it's a second degree type 2 and not a third degree. And even in the test, I'm not going to give you something like this as second degree type 2. This is not what I'm testing you on. What I want to test you on is, do you recognize that there's drop QRS and that it's a regular PR interval? That's what I'm testing you on. And this is a high grade block, and these people can misinterpret these very easily, especially in the hospital setting. So I want to make sure but this is you're using your skills to be able to identify, interpret it. But on the test, I'm not going to be doing that. All right, my goal on the test is not to trick you. All right, do you want to do 2 more, 1 more? How many more do you want to do? How many pages is this? Oh, I think we only have one left. So what is this? This looks irregular. All right, just looking at it from a distance, I got something going on here, something going on here. This is not a regular rate, right? Well, now that I draw it, it kind of looks, but I got gaps here, right? Because there's probably something missing. And what's missing? A QRS, right? So the next step is the PR interval getting longer, or is the PR interval consistent? So what's going on? That looks, let's go back over here. So this PR interval is nice and nuzzled. This PR interval is getting longer. This PR is getting even longer, right? So what is that? It's a second degree type 1. You gotta be careful. It's a second degree type 1, right? That's what threw me off before. I think I said type 1 and that was on second degree mode. All right, but yeah, so second degree type 1 block. Okay.
So even if it gets longer than normal, longer, it's still going to be type 1.
Second degree type 1. So if it gets longer and drops, it's a secondary type 1. The question was, what if the first PR interval is normal? Well, the last one wasn't. So, but either way, yeah, the fact that it's getting longer is what's making us think it's or what confirms it with us that it's going to be a secondary type 1. All right, so decision tree, there's nothing there. All right, anyways, so I'll submit this PDF as well. So the next thing was look at idioventricular and junctional rhythms. Test bank, library, PDF, right? So, yep, let's see what this has. Does it have examples? No. EKG library, let's do test rhythms. Are these all junctional or are these just, let's look at the answers real quick. That doesn't help. BCC, EDF. We can save that for later if you want to look over lethal rhythms. But let's go over here. Basic practice tests, junctional rhythms, idioventricular rhythms. Only 3 pictures there. 150. I should have done 100 plus. Look at that. 150 practice. And this was just what? This is all of them. It's like a whole book. So that's not gonna, I have a headache already. Arrhythmia review sheet, idioventricular rhythms. Got a chat here. So from before, second degree type 1 gets longer, and type 2 is PR is the same and the QRS drops. So that's correct. Right. So I know on FA Davis, I have access to an EKG book. So we'll try that next. If a free study guide. Habido un error critico. It sounds like I have a critical error. Nope, no luck there. Let's put examples. Maybe it was just too specific. EKG reviews. What's the difference between, okay, accelerated idioventriculars? EKG Academy, that sounds good. This is accelerated junctional rhythms categories. So this lets you really, for sure, be able to differentiate. So if like when I look for junctional tachycardias or accelerated junctional rhythms, probably has a whole bunch of examples, hopefully, or not. That didn't pan out. I got optimistic, sorry. This tells you the difference between the junctional versus idioventricular, where they're coming from. So you got 20 to 40, 40 to 60, right? All right, so I might go into FA Davis and see if I can log on there. I have to remember my instructor login, because they gave me a login. This looks familiar. Take me to Davis Plus. Okay. Instructors, access resources. Oh, okay, good. All right, so EKG Mastery, open ebook. I know this had chapters, and the chapters were like on junctional rhythms, but you could probably do that on Google as well, junctional chapter. There's some practice, like complete practice tests, but that's do rhythms and their analysis, junctional rhythms. So this is just straight up junctional rhythms, right? Although we have to look at our answer afterwards, but that's a lot of practice. That's good. But this is junctional. I don't know if it has idioventricular built in. Let's look at the answers real quick. Let's peek at the answers. So we got junctional tachycardia, accelerated junctional tachycardia, AFib with RVR. That's fancy. Sinus tachycardia, peak T-wave. So it's actually letting you differentiate. So that's good. Junctional. So we don't have idioventricular here. We have to practice those next. Okay. All right. So let's go back up and do some junctional rhythms. All right. So 5-1. That's probably just straight up junctional. All right. So let's look at this guy. All right. So what do we have here? We have a rate of what? We're going to line up with a solid line, right? So you got 300. What's next? 150, 100. It's got a rate of 75-ish, right? And now the next step is looking at the P wave, or looking at to see, is this sinus rhythm or not? And it's like, well, it could be sinus rhythm. That P wave looks a little funky. This P wave is upside down. This P wave is upside down. That's not sinus. Why is that P wave upside down? There's like no P wave here, right? This P wave is upside down. So that being said, that means that's a feature of junctional rhythms. Junctional rhythms are right at the junction, right? So the next step after AV blocks. So if we draw a heart here, right? And here's our AV node, SA node's over here. And we had come down, and then we have our bundle of His, right? So our junctional rhythms are, or our AV blocks were right here, right? That's an AV block. A junctional rhythm is right here. Sorry, let's undo that. Point better. Right there at the junction, right before the bundle of His, right? And the intrinsic rate of the junction is what? 40 to 60. The whole AV node and junctional area is 40 to 60. Okay, so that's where our junctional rhythms are at. Idioventricular rhythms are down here. It's a different color. That's not different. Brown. Idioventricular are right here. They're after the Purkinje fibers. They're 20 to 40. Right? So that's what we're seeing here. We're seeing P waves that are trying to get through, but they can't. Right? They're like upside down. If it came from over here, the P wave would be upright, right? If it came from down here, you're going to see like inverted or weird P waves, or no P waves at all, even. Okay. So it's like upside down P wave, or the P wave is like inside the QRS complex, make the QRS complex look funny, or the P wave could be after.
That looks like that could be the P wave.
This one right here?
Yeah, how do you, like, right, that one that you circled, there's like,
This one?
just before the QRS, there's like, it bumps up. So it's like, that could just be
It's,
really
yeah,
cool.
that's just an inverted P wave. Yeah. So there's just an inverted P wave right here. Right. If you look at other P waves, it could be like inverted like this. There could be no P wave. It could be after the QRS complex, right? And you got a little inverted P wave in the ST segment. So your P wave is hidden, right? And it's hidden because it's not getting through. It's trying to do it, right? It's still doing its thing, but it's not getting through. It's the junction. It's like almost like a complete block. Okay. So we have this junctional rhythm here. And it's a junctional rhythm, but again, we have 3 varieties, right? And the varieties are 40 to 60, 60 to 100, or 100 plus. So what is this one? So this is accelerated junctional, right? Accelerated junctional rhythm. If it was more than 100, it'd be called what? Junctional tachycardia. Right, so let's see some more. This one looks too fancy, but it looks fast. And if this is the junctional rhythm chapter, I'm probably thinking it's one of the junctional tachycardias, but let's not cheat. All right, so we have what's going on. All right, so we're not seeing any kind of P waves here. I mean, got a little P wave deal maybe there, but it looks like my P wave is kind of almost after the QRS complex. That looks like that might be my QRS. Sorry, my P wave is after my QRS there. I think those are my little P waves. Okay. There's no P waves before. Okay. This little notch right here is probably just it's just the Q, like when you draw a QRS, right? So QRS, all right? So I think that's what we're just seeing there. Okay, so we have a junction rhythm, right? We have a junction rhythm. We also have a PVC here. That's allowed, that's legal. All right, so we have a junctional tachycardia, accelerated junctional, or junction rhythm. We got 300, what's next? 150, 100. And we have a 75 to 100. So I lied. So I mean, that's why you gotta mark it out, right? But the other piece here is this is an irregular rhythm, right? Because we have PVC, so technically we can't use this method. So we have to get a 6-second strip. So that's 2 hash marks, right? We got 1, 2, 3, 4, 5. If you can argue 5, it's a rate of 50. This is tricky. So I would not put this on the test. Okay. So that is 6 seconds, right? Yeah, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Or no, those aren't 6 seconds. All right, so 2, 4, this is 1 second. So maybe this whole thing is 6-second strip, right? So their hash marks are different than traditional hash marks. All right, do you follow what I'm saying? So the hash mark usually delineates 3 seconds. I think they're delineating 1 second marks. So 1, 2, 3, 4, 5, 6 seconds. So this is a 6-second strip, the whole thing, right? And for irregular rhythms, you do the number of complexes at 6 seconds. You multiply by 10 or 6. What do you do? Multiply by 10. So how many complexes do we have? All right, how many? We said 13. As long as more than 10, I'm happy, because that's tachycardia at that point, right? That's junctional tachycardia. All right, if this was idioventricular, it'd still be accelerated idioventricular. But with junctional rhythms, you have 3 varieties: traditional, accelerated, and junctional tachycardia. So the junctional tachycardia with PVCs. All right, and why is it a PVC, not a PAC? It's wide is the big reason. Okay, if you have a wide QRS, it's a PVC. If it's a narrow QRS, it's a PAC. Now there is something out there called PJCs, but we're not testing on PJCs. All right, let's save that. Let's go to the next one. So this one, that looks irregular. So what's going on here? Usually junction rhythms are regular usually, but anyways, we have I know what's going on. And this is what I said we would not test you on, which is PJCs. All right, because PJCs and PACs, the only difference between those is the presence of a P wave or not. All right, let's skip this one. That's too fancy. Can't afford that one. All right, this one that we can afford. All right, so here we got a P wave, but it's inverted. That's unusual. If you see an inverted P wave in the test, I'm probably asking you to see if that's a junctional rhythm or not. All right, I'm not testing on biphasic P waves and such. If you see an inverted P wave, it's a junctional rhythm. So we have an inverted P wave, therefore it's a junctional rhythm. But the other way we know this is not idioventricular, right? Because idioventricular rhythms, don't have P waves, right? And also idioventricular rhythms have what other feature? They're wide, right? They're guaranteed wide. Junctional rhythms can be wide, but again, I'm not going to test you on those other uncommon situations. So if there's a narrow and a P wave that looks weird, that's a junctional rhythm as far as you're concerned. Okay. And then the rate. Here is 300, 150, 100, 75, 60. We can stop there, right? Because if we're less than 60, we are what? We're either traditionally idioventricular or actually we're not idioventricular yet, but we are just straight up junctional rhythm. It's just a junctional rhythm, right? So let's save that, clear. Next one. Okay, this guy right here. What is this? I have inverted P wave, right? I have a narrow complex. What's the rate? Unfortunately, nothing's lined up perfectly, but I'm still going to use this in this box right here. 300, 150, sorry, 300, 150, 100, 75, 60. It's less than 60, therefore it's what? Junction rhythm with ST elevation, right? Next one, that looks fast, and that looks, it's not out of control. You should be able to get this also. So what's going on here? We have no P wave. That's concerning. The only other rhythm I told you that has no P wave is idioventricular and also SVT, right? PSVT is a super fast rhythm over 150 that has no P wave also, right? But this is, we'll figure out what this is. But either way, I got no P wave going on here, right? No P wave, no P wave, no P wave. So what is that? I got, what's this wide and bizarre situation here? That's on every other beat. Yeah, those are PVCs. That's a bigeminal PVC, right? It's every other beat. So it's a junctional rhythm with bigeminal PVCs. What kind of junctional rhythm? The junctional tachycardia, accelerated junctional, or regular junctional? It's not regular. That does not look slow. So we determined this is a 6-second strip from here to here. It's not technically irregular, but so we could use the 300 method too, right? So from here to here is 300, right? But if we use the other way, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, or it's 160, right? So really, I think it's probably right there. It's probably like 170 is probably the rate. Okay. So yeah, so this is a rate of 160, 170, 150-ish. So that is going to be what? Junctional what? Junctional tachycardia with PVCs, with bigeminal PVCs. All right, do you want to do more of these? You want to move on to idioventricular? Let's save this drawing. Let's see, that's probably under ventricular rhythms. It's probably going to mix in some idioventricular. So let's scroll down. I do not want to highlight. Stop. Okay, that's annoying. Anyways, let's go to this guy right here. Oh, that's a example. And it also has some VTAC mixed in there, VFib and torsades. So this will be good practice too. All right, so it's probably going to test you on lethal rhythms first. All right, do you want to go over lethal rhythms or you go with lethal rhythms? All right, so we got a consensus. We're going to do some lethal rhythms. All right, so let's look at this guy. All right, so what is this? That's wide and fast. And as far as you're concerned, we're not going to test you on a wide and fast SVT. As far as you're concerned, if it's wide and fast, it's what? VTAC until proven otherwise, right? So that's VTAC, right? It's wide and fast. How do I know how fast it is? This guy lines up 300. It's faster than 150, right? And it's a wide QRS, right? But there's no P waves. It might be PSVT. No, if it's wide and fast, it's VTAC to prove it otherwise, right? I'd have to see other criteria to tell me if it's actually VTAC or SVT. And if I really were to truly look into it, it probably would be VTAC. Okay, so this is VTAC. How do you treat VTAC? Or VTAC is tricky because it's the only lethal rhythm that has with a pulse, without a pulse. So if there is a pulse, what do we do? Synchronized cardioversion. We can still give meds as long as the blood pressure is good, right? And what meds can you give if the blood pressure is good? Amiodarone is the only one I gave you. Lidocaine I kind of mentioned, and the only difference is if they have a QT prolonged or not. But yes, amiodarone and shock are the ones we're going to do. And what would tell us whether we're going to go straight to shock and not pass go and not collect $200 is if the blood pressure is what? Low. If blood pressure is less than 90, we skip always any rhythm. We always skip to shocking. Bradyarrhythmia means we shock them at 60 beats per minute. But with these guys, we're going to do synchronized cardioversion if the blood pressure is less than 90, whether it be a tachyarrhythmia like this one, right? Your PSVT or AFib or AFib or your tachycardia even. Yeah, that blood pressure gets less than 90, we are shocking no matter what. And we're doing synchronized cardioversion. The only time we switch over to unsynchronized cardioversion is when? No pulse, right? So if there's no pulse, we're shocking them, right? And then we're shocking them if they have a shockable rhythm, right? So what are the shockable rhythms? VTAC, which is there's monomorphic and polymorphic, meaning regular VTAC and torsades. And what's the other shockable rhythm? VFib, right? There's only 3 rhythms that we shock. anything else, which is PEA, and what's the other? Asystole. So you have to make a chart, right? Because that you're gonna get crazy. There's no way, it's hard to memorize that. You can't say, well, I got this and this and this and this, then I got that, right? You have to make a little chart, a little flow chart, or you get a little table, so that way you know exactly what's like. Then you have like geography, right? You have the first 3 rhythms are my shockable ones, and the bottom 2 rhythms are my non-shockable. And then you can use colors, right? Make them blue for non-shockable, right? And then you can when you're on the test, I can't remember that shockable, non-shockable, but asystole was in the blue section, and that was at the bottom, so that was the non-shockable, right? So you're going to increase your odds. So moving on, I got distracted. All right, so next one. What is this next one here? So this one I think is just because this chapter also went over PVCs, I believe. I got a PVC looks upright like that. I got a PVC looks downright like that. That's dangerous when you have PVCs that are like that in different directions. It's called multifocal PVCs. Right. And on the test, I'm not going to test you on whether it's multifocal or unifocal. Right? Just that, can you see that it's a PVC or not? Right. So there are PVCs there. There's nothing else weird here. I think this is just trying to test you to see if you know that it's a PVC. Right. So it's sinus rhythm or sinus tach or sinus Brady. If this is a 6-second strip, is this a regular rhythm or irregular rhythm? That's irregular. So we have to do what? 6 seconds. We got 1, 2, 3, 4, 5, 6, 7, 8. So it's sinus rhythm with multifocal PVCs. All right, let's clear all that. Going down. Oop, that that should make your heart flutter like this, right? Don't not like that. All right. But what is that? That's wide and fast. All right, it's definitely fast. If you look out, beat to beat, it's like 270, 280. Is that rate? Okay, so that's VTAC, right? This guy, this is the one we tried to, that's the reason why we came here. We got no P wave, so it might be junctional, but what tells us it's not junctional could be the rate, but also it could be the QRS being wide, right? That QRS, if we line this up, this kind of one kind of lines up, right? It's definitely more than 0.20, sorry, 0.112. I think that's kind of where it ends right here. So this one box over here, 2 box, 3 box is definitely more than 0.12. It's like 0.13, 0.14. And what's the rate? Line this guy up here, right? So it's definitely slow, right? So 300, 150, 100, 75. Right, the next one is 60. The next one's like 55, and the next one's like 35. But I'm not going to test on that. I'm just going to make sure if you know it's wide and no P wave, it's a idioventricular rhythm. Okay. So you could argue that's accelerated idioventricular, but I would make it obvious that's accelerated idioventricular. It would definitely be greater than 60, right? Mm-hmm. Correct. So what do we get for this? I mean, this is probably, what is it at? Is it 35? I think it's just right there, right above 40. Right. It's just before 40. And 20 to 40 is idioventricular. More than 40 is what? Accelerated idioventricular, right? All right, let's get some more here. What is that? Has no pattern whatsoever. That looks fibrillatory. Is it AFib or VFib? It's VFib, right? AFib has QRS complexes, right? So this is VFib. How do you fix VFib? Defib it, right? And we're not going to wait and give amiodarone first, but you can give amiodarone because it's for ventricular rhythms. This is a ventricular arrhythmia. But the first priority is to do CPR, right? Do CABs, CPR. We're going to worry about airway later. It's like they may have gone into this because just before this, they were hypoxic, right? So we look at H's and T's as the treatment, right? So it's like they were hypoxic. That's what caused this. We saw them come in. They were really short of breath. They were tripoding. They were desatting. And then all of a sudden they went VFib, right? So we look at reversible causes, right? So yes, during the whole CPR and everything, we're going to get an advanced airway with the ET tube and get them on the ventilator and such. but the priority is to fix the underlying rhythm, right? We're going to shock them out of that rhythm. We're doing CPR, and then we'll worry about that airway next. Okay. And amioto you can do for funsies. All right, for this one, we got some PVCs in there, right? Are the PVCs or PACs? How do I tell the difference? The wide is where I'm going to start there first, right? They got a wide QRS complex. So that's some PVCs in there. And we have a fast rhythm. We got 300, and we got a rate more than 150. Right, so I have no P waves. So usually if it's a rate more than 150, technically, if you look at some other sources, which is clever, and I think it's also in the PowerPoint, if you look at comparing rates, all right, you can see you have junctional rhythm, accelerated junctional tachycardia, and then you have PSVT. So this is PSVT, right? Because there's no P wave. And sometimes the P waves are buried elsewhere. So this is PSVT with PVCs. All right, next one. What does this next one look like? It looks like torsades. Someone has their scarf on in the back. Someone said torsades, someone else said not torsades. All right, next one. What is this? You could argue with PVCs, but PVCs usually interrupt a normal rhythm. So I think the PVC is the one that is this one, right? I think this is the regular rhythm right here. We got a wide QRS. We got no P wave. And we got a rate that looks super, super slow. So what is that? That's idioventricular. All right, next one, clear. What rhythm is that? It looks like asystole. And you could argue it's coarse, fine VFib. There's a little bit of fibrillatory waves in there. But again, on the test, I'm not going to test you fine VFib versus asystole, right? In real life, we would shock them just for the heck of it because they're already dead. It's not going to make any difference whether we shock that or not. But if it's like, you can really tell it's pure asystole versus this. And sometimes if it's arguable, we'll shock it anyways, because this is a shockable rhythm if you interpreted this as VFib, right? Which you could do. Next one, we got P waves. What is going on here? The P waves look normal, like PR interval looks normal. So I'm not sure what they're trying to test us on. I'd have to see if is the R to R looking different? Are there like PACs hidden here or something? Notice the slight wave in the baseline due to respiratory artifact. I was trying to tell you about artifact. So yes, we have got some respiratory artifact in there. So the sinus rhythm or sinus tach. It's not sinus brady. It doesn't look slow enough for sinus brady. It's not irregular, so we can't multiply by 10. So we got to line up with a complex. This guy lines up nicely. All right, so we got 300, 150, 100. Did that right? 300, 150, 100, 75, 60. Oh, that's why you check. I said it couldn't be bradycardia. It doesn't look slow enough. But if we actually measure it, it is slow enough, right? So that's a what? Sinus brady with respiratory artifact. That's what I do. I zoomed in. I don't want to zoom in. All right, so let's move on to another idioventricular rhythm. It looks idioventricular-like. This one looks idioventricular-like. That's a little bit tough. It's saying this one looks what? This is junctional. This one, look, it got, they call them retrograde, which means inverted, right? Means they're backwards, and there's no P waves there. So how do I know this is not idioventricular? Because that QRS is not greater than 0.12, right? So the QRS is not greater than 0.12, therefore it's not idioventricular. So the next step is it accelerated idioventricular, accelerated junctional tachycardia, or just regular junctional? So this one lines up, right? 300, 150, 100, 100, 75, 60. So it's less than 60, right? So that's going to be So it's junctional what? Junctional, right? It's junctional rhythm. If it was more than 60, it would be accelerated junctional. If it's more than 100, it would be junctional tachycardia. If it's more than 150, it would be paroxysmal SVT. All right, but let's do like one or two more. Let's look at another idioventricular rhythm. That looks like a flutter right there. 1, 2, 3. That's an a flutter rhythm with some PVC couplets. This one looks funky. What's going on here? There's no P wave, so it could be junctional, could be idioventricular, right? Let's look at the QRS complex. Got 1, 2, maybe 2.5 boxes. So that's what? It's less than 0.12. Therefore, it's junctional something or something junctional, right? If it's accelerated. So let's line up the QRS complex to a waveform. They don't kind of line up exactly, but we'll take it. All right, 300, 150, 100, 75. It's more than 60, right? So more than 60 means accelerated junctional, right? And it's saying with ST depression too. All right, save that one. Let's go next one. What does that look like? That's a flutter, right? With a PVC. This one just looks like a fast rhythm. I think got some PVC in there. And this one looks traditional. What is this? Slow something, but what do we have? We got a no P wave. No P wave tells us it's either junctional or idioventricular. We got a definitely wide QRS. So we got 1 box, 2 box, 3 box, 3.5 boxes at least, right? If we measure like this lines up with the line, and that's the box it goes to. So it's like almost 4 boxes wide, right? So it's like 0.14, right? As the QRS. So we get a wide QRS and we have no P wave. So what does that equal? Idioventricular some type. So is it accelerated idioventricular or regular idioventricular? Which one is it? So let's line up the QRS complex here, right? So you got 300, 150, 100, 75, 60. Next one will be 50, right? So it's more than 40. So it's an accelerated idioventricular rhythm. Here's the PVC. Here we have no P wave, right? No P wave there. Where's the P wave? In the ST segment, all right? So it's not a third degree block. They're not dissociated. All right, their AB node still works a little bit, but either way, we got this P wave that's buried inside the ST segment. The fact that we have a P wave, it's not idioventricular, right? QRS is about 1.5 boxes at best, right? 0.10. So this is a junctional rhythm. Is it, and it looks fast. I can confirm that. Is it accelerated junctional or junctional tachycardia? 300, 150, 100. So it's between 100 and 150. Therefore, it's a junctional tachycardia. P waves, that has P waves and big old PVC right there. It's just like a bradycardia. It's not even a first degree block yet. That looks like what? What is that? That's a flutter. It's a very, very slow a flutter. Someone that has a flutter, they probably came in tachycardic and we gave treatment, right? What's the treatment for a flutter? A, B, C, D. So amiodarone, beta blockers, non-DHP calcium blockers, and digoxin. And then this is why they go to the tele floor to be monitored. We can monitor them at least once or twice a shift to make sure those medications aren't getting toxic, right? So if they're getting digoxin and they're getting dig toxic, how would you know they're getting dig toxic, or what would potentiate dig toxicity? Their electrolytes would be abnormal, right? So obviously bradycardia. Also, you can check dig levels, right? That would tell you that you can dig toxic. You get a projectile vomiting, got yellow halos, right? Also, they're probably not feeling good with this. They'll have short chest pain, shortness of breath, hypertension, confusion, maybe, right? So these are all kind of putting everything together as far as bradycardia is concerned. This kind of falls into bradycardia territory. And if we treat these A flutters with ABCD, but as soon as they start getting a blood pressure less than 90, what do? You got a we technically, yes, you shock them, but you shock them at 60 beats per minute, which is called pacing, right? You're going to pace them as soon as they get hypotensive. All right, so we kind of spent an hour on that. Does that help? Okay. So the only other piece that people usually get confused with is pacemakers, right? So pacemakers in there. So you mean someone, if you want to have a study group, you can pitch in $20 each, whatever, how much it costs for this book here, EKG Mastery, right? But any EKG book online probably that has examples, right? They're going to advertise it, say it has, 1,000 EKGs, right? This one is EKG Mastery. All right, any questions from the chat? We're good. All right, so I'll save this video and I'll save all the notes to the Google Drive shared folders that you have access to it.